Hello, everyone, and welcome to the very first episode of the Dose of Truth.MD podcast, a platform dedicated to simplifying complex medical topics and bringing authentic healthcare insights straight from experts to you. I am Dr. Pranav Joshi, resident in pharmacology in IMS BHU, Banaras, and today's session will be hosted by my colleague Dr. Abhilasha Nanadikar, my co-resident in pharmacology. Today we will be discussing an increasingly common yet under-recognized condition, metabolic dysfunction associated steatotic liver disease or MASLD, formerly known as fatty liver disease. To help us understand this important topic in depth, we are truly honored to have with us Dr. Viraj Suvarna, an eminent name in the field of clinical pharmacology and pharmaceutical medicine. Dr. Viraj Suvarna sir is an MD in pharmacology from Grant Medical College and the Sir J. Group of Hospitals, Mumbai, and also holds an MSc in pharmaceutical medicine from Hibernia University, Dublin. He stood first in Mumbai University, receiving prizes for topping anatomy and pharmacology from Topiwala National Medical College and BYL Nair Hospital, Mumbai. Dr. Suvarna brings with him an illustrious 27 years of experience in the Indian pharmaceutical industry, having worked with leading foreign MNCs like Pfizer, Boehringer Ingelheim, and Roche, as well as Indian MNCs such as Biocon, DRL, and Lupin. He is currently serving as the medical head of an advertising and research company where he creatively conceptualizes and designs the medical strategy and scientific communication for various pharmaceutical brands across both Indian and global market. Let us all welcome Dr. Suvarna for joining us today. It is an absolute privilege to have him as our first guest on Dose of Truth.MD. In today's conversation, we will dive into what MASLD really is, why it's becoming so common, and who is at risk, and most importantly, what we can do to prevent and manage it effectively. So let's get started, and together, let's decode the truth about MASLD.
Today, the topic that I have been asked to speak on is on MASLD, which stands for Metabolic Dysfunction Associated Steatotic Liver Disease. Now, obviously, if you all are doctors, then you would understand, but I also understand that there are some, how do I put it, non-doctors or people who are just from the general public also who may be interested in listening to this particular talk. So for them, I'll try to make it a bit easier. Having said that, I also want to tell everyone that I'm basically a pharmacologist and not a hepatologist or a clinician who deals with patients who have diseases of the liver. But because of my more than 27 years of experience in the industry and a fair amount of subject matter expertise in this condition, I guess it's okay for me to also just tell you all about this condition. And then obviously, if you need anything which is more clinically oriented, then it's best to see a hepatologist or a gastroenterologist. Both of them are like specialists as far as the liver is concerned. So what you're seeing in this slide is something which is very typical. All of us see this. This is, of course, a male, but even females have this, what we call central or abdominal obesity. That means the paunch. And in this entire condition, metabolic dysfunction associated steatotic basically stands for something to do with fat. So whenever there is fat deposition, particularly in an organ where normally fat is not stored. So fat, as you know, in the body is stored in what is called as adipose tissue. But if there is excess fat, then sometimes from adipose tissue, which gets overwhelmed with all that fat, the fat also goes and then gets deposited in certain organs like the liver, the pancreas, the skeletal muscle, the heart, the kidneys, etc. So here, of course, it is when the liver cells have what is called as triglyceride, which is nothing but triacyl glycerol, or glycerol, which is a sugar alcohol, and 3 fatty acids associated with it. So that's why it's called triacyl glycerol or triglyceride. So when more than 5% of liver cells or hepatocytes have this triglyceride deposition, that is when it is called steatotic liver disease. And when that is associated with what we call metabolic dysfunction. Now, metabolism, you all would understand, is nothing but, when we eat, there's something known as catabolism or breakdown, for example, of protein and carbohydrate and fat to its absolute, final element, which in the case of carbohydrates would be glucose, in the case of protein would be amino acids, in the case of fat it would be fatty acids. And then, of course, all this is utilized for energy. And then the remaining is stored. And that is, again, it's a form of, a breakdown, as I said, catabolism, and then a buildup, which is called anabolism. And the composite of both is called metabolism. It's basically how food is processed in the body and how these 3, carbohydrate, protein, fat, the metabolism is also interlinked. So if there is some dysfunction and it leads to more fat being stored in the liver rather than where normally it is stored like the adipose tissue, that is called metabolic dysfunction associated steatotic liver disease. So to understand this, we also need to understand that what exactly is this metabolic syndrome that we talk of. And metabolic syndrome actually, as the word syndrome itself would tell you, it's a constellation, it's a combination of, in this case, 5 different features. So one is the person has, as you can see, central abdominal obesity, and that can be measured by using what is called as waist circumference. Then, of course, the person has hypertension, and there are values for all of these. Then the person has typically Indians have this when they have what is called as dyslipidemia or disorder of lipid metabolism. So they have high triglycerides and low HDL cholesterol. Then, of course, all of us know about diabetes. Yes, what I was basically trying to explain is metabolic syndrome, where there are 5 parameters, and I covered central abdominal obesity, hypertension, dyslipidemia, and also what we call pre-diabetes, where you have a fasting plasma glucose of anything more than 100 milligram per DL, or an HbA1c, which is 5.7 to 6.4, because 6.5% or more is considered diabetes. But if it's in that range of 5.7 to 6.4, it's called pre-diabetes. And if you have 3 out of these 5, then you are said to be positive for this metabolic syndrome. So generally, MASLD is when you have fat deposition in the liver, more than 5% of the liver cells or hepatocytes, and associated with metabolic syndrome. But at the same time, it is not because of an excessive consumption of alcohol. So in the past, this condition used to be called non-alcoholic fatty liver disease, or NAFLD. But then people decided to change the terminology because it was becoming a little confusing. And that's why they removed this term non-alcoholic and they called it metabolic dysfunction associated steatotic liver disease. And the reason why it is so important and why we are talking today is because it is quite prevalent in India. In fact, 1/3 of every Indian, actually, if you do an ultrasonography of the abdomen, you are likely to find triglyceride deposition in the liver. And that is the reason why even today we're talking about it, because it's pretty common. And the reason is not alcohol related, it's actually the diet. And purposely I have put there as MACHO. MA is, of course, middle age. And here also the central abdominal obesity is where you are aging in the middle. That means in your paunch. And CHO basically is, a symbol for carbohydrates. And that's what I want to talk about. The fact that we eat a lot of carbohydrates in our diet, much more than what is normal. So typically we are supposed to have only 50% carbohydrate in our diet, 20% protein, 30% fat, and of course fiber. But we have something like 65 to 75% of our diet is actually carbohydrate. So we are what people call carnivorous, and that is not good for us because that excess carbohydrate that we eat ultimately leads to all these problems. So that is why it's extremely important. And it's easily preventable because if you adopt the right lifestyle and you don't have so much of carbohydrates in your diet, and even if you're having carbohydrates, you need to have what is called as complex carbohydrates rather than simple sugars. So that way, at least, the breakdown to glucose and the release of glucose into the bloodstream is very slow and uniform. It's not sudden like a spike. And that is something which enables our body, like the pancreas in particular, where you have something called as beta cells in the islets of Langerhans, which secrete insulin. So that is then done in a very balanced and controlled manner. But if you eat like, what people say, white sugar, white bread, white rice, and that kind of diet, then obviously the sugar level, these are foods with a very high glycemic index. So the way glucose enters the bloodstream and the way it increases and reaches a high level like a spike, that causes so much of insulin to come out, and that ultimately is the start of this particular problem. So now I'll go to my second slide, where what I want to tell you all is in this slide that these two individuals that you're seeing on the slide, the Indian-looking one is Dr. Chitranjan S. Yajnik. He is a very famous clinician, researcher, diabetologist based in Pune, and his friend and counterpart who hails from Sweden, his name is Dr. Yudkin. So that's why Yudkin and Yajnik paradox. The paradox is that if you look at both these individuals, you will think that Yudkin has more fat as compared to Yajnik. But when they did what is called as a body fat estimation, they found Yajnik to have more fat. And that is what is called the YY paradox. And Indians in particular, they say, we may look thin, but we may have a lot of what is called as visceral fat. That means fat which is not in the adipose tissue, but in organs or viscera like the liver. And that is why, people say that Indians now have this thin fat Indian, and I've deliberately put sick fat Indian because this fat also, it's not just maldistributed. That means instead of being in adipose tissue, it is in the liver. It is also sick. That means dysfunctional fat or adiposopathy. So ultimately, it is excess adipose tissue mass in the body, then maldistributed and dysfunctional. And that actually is what we call adiposity or obesity. It's not just body weight. It's also about the fat in the body that determines whether you are obese or not. It's not just BMI. BMI, as you know, is just the weight in kilograms upon the height in meter square. But that may not necessarily be very accurate in terms of defining who is overweight, who is obese. And as you know, among Indians, in fact, the cutoffs are even lower. So that's why I've just put this, it's like a pun on the word liver. So one is a liver is a person, who lives. And second is we're talking about the liver in our body. So Indians are fatty livers. That means most of us, 1/3, 1 in every 3, we actually have what is called as fatty liver. And then, of course, many of us have metabolic dysfunction associated steatotic liver disease. And then I'll show you how it progresses from there into something called as MASH, or metabolic dysfunction associated steatohepatitis, where
Yes.
now there is inflammation of the liver, and then it goes to fibrosis, then cirrhosis, and eventually hepatocellular carcinoma or cancer. So it's a pretty, I would say, dangerous thing to have. And people say that even when you have just metabolic dysfunction associated steatotic liver disease, still you're at high risk because it is an independent risk factor for cardiovascular disease. So that's why we need to be careful if at all any of us has this. The statistic which you're seeing right on top of the slide is from Harrison's Principles of Internal Medicine, just to give you information that we have something like 35 billion fat cells in the body. And they are actually specialized to contain fat because they have this unilocular fat droplet, and they have a single layer of phospholipid which can hold that triglyceride because it contains all the components needed for enzymes that make and break down triglyceride as needed. So, responsive to metabolic requirements of the body. So, adipose tissue, yes, they can handle fat, but other organs, when there's too much of fat in the body, and that fat actually has come from carbohydrates rather than only eating fatty food. It's more about carbohydrates than fat. And that excess fat, then when it goes to the liver, pancreas, etc., that is what we say is dangerous fat, because it produces certain cytokines which we call adipokines, because even the adipose tissue is now considered the largest endocrine organ in the human body, and that is really dangerous for all of us because it can lead to lots of problems. I'm now moving to my next slide. This is just to tell you where all the fat can be stored. So not just subcutaneous, which is okay. It is something which all of us can see, and therefore we feel, oh, this person is fat, obese, or overweight. But it is what you can't see, which is also important. Like one is, of course, intra-abdominal fat, hepatic fat, even in the arteries, blood vessels, in the skeletal muscle, pancreas, and actually even in the brain, in the lungs, in the kidneys, all over. So it's almost as if, like how there is a condition known as endometriosis, where the endometrium or the inner lining of the uterus becomes ectopic. Here, it is like fat is becoming ectopic. So who knows, like endometriosis, maybe you can call it adiposiosis, or, like we say METS, which is metabolic syndrome, but METS can also remind you of metastasis, in cancer. So this is also almost like fat cells metastasizing to other parts of the body. And by the way, diabetes and obesity are not only diabetes, obesity, but also cancer with what we call diabesity, means diabetes and obesity. They are also very closely linked. And very soon you will see this, another kind of a epidemic or pandemic, not of the infectious kind, but that is also a pandemic, because globally you'll find diabetes, obesity, and cancer will be very closely linked. That is again why we need to take care. And that is why Hippocrates, long time ago, he had said that our food should be our medicine, because if food is not your medicine, if you don't eat the right kind of food, ultimately your medicine will be nothing but, your food will be nothing but medicine. All the time you'll be taking medicine, at least 10, 12, because nowadays in some of these prescriptions, you will see doctors writing so many different medicines, and that has become our food. So it's important that we eat the right kind of food. And that's why that RX symbol also, which incidentally stands for recipe. Recipe again has something to do with food. And the RX also, you can divide it into the D, which is diet, the X, which is exercise, and then the RX, which is drugs. And both these textbooks that you can see here, Cross's textbook and the Modern Nutrition, Health and Disease, these are excellent textbooks which nutritionists, registered dietitians and nutritionists, they are the ones who master these books. But I think every doctor also, including pharmacologists, should know about these books, because then you'll understand about how nutrition can ultimately, nowadays people call it medical nutrition therapy. I'm not saying you don't need drugs. Obviously, you will need drugs, but diet, exercise, in fact, behavioral therapy, especially for obesity, and then, of course, drugs, and in some cases, even bariatric surgery. So the reason why this has become such a huge problem, and this is, of course, a map of the world in terms of prevalence of diabetes, and you'll find that India, China, they look very bloated, grotesque. It's like, the shape of India, very nice shape, but now India's shape has become, it's too, there's so much of a bulge there. So can we get India back into its normal shape? That is what is important. People talk of India and they want to get back Pakistan, Bangladesh, because we were India at one point. Forget all that. What is important now is India itself is ballooning, like China, and it's going all out of shape. So can we bring India at least back to shape? See, look at the statistics as far as obesity is concerned. We know that India very soon in 2027, 28, or maybe by the end of this decade, 2030, will be the third largest economy after the US and China. But in obesity, we are already the third largest, again, after US and China only. So it looks like the top three countries in world economy are also the top three countries in terms of obesity, diabetes. And this is why some people, when you look at the paunch, people say it's a sign of prosperity. It is not a sign of prosperity. It is a sign of disease. That's why obesity is now called a disease. 70% of urban India is overweight. 8 crore Indians are already obese. And I'll show you a slide later on. BMI, to define obesity among Asian Indians, is not 30, 25, and 23 to 24.9 is overweight. Whereas for Westerners, Caucasians, overweight is 25 to 29.9, and 30 and above is obesity. But for Indians, Asian Indians, it's actually 25 onwards. So many of us are obese. And not only that, even among children, adolescents, young adults, 18 to 25 years, there is increase in obesity. There is early onset type 2 diabetes. In fact, if you read Lancet, there are 3 articles as a series which are only focused on early onset diabetes. And less than 10 Indians per the ICMR INDIAB survey are physically active. So we need to actually move more and eat less of these refined carbohydrates or ultra processed food or sugar sweetened beverages like, these drinks like Coca-Cola, etc. All that we need to reduce, or even the trans fats. So it's important that as long as we stick to a balanced diet, we'll be fine. And of course, some form of exercise and behavioral therapy or counseling, so that even mentally we are absolutely healthy. That is extremely important. This is just to tell you how we have evolved. And the word adiposity, if you just, it's an anagram. If you rearrange it, you get diaposity, which is diabetes, adiposity, because the two are linked. And this is the definition of obesity. It's excess adipose tissue mass, which adversely affects health. So simple. And then, of course, that same excess adipose tissue mass can be maldistributed, can be sick or dysfunctional adiposopathy. And that is something which accompanies obesity. And obesity, by the way, is the gateway to 229 plus medical disorders. This is the cutoff that I was telling you. 23 to 24.9 is overweight, 25 and above is obese. And if you want to know about body fat, for men, it is anything more than 25.5%, and for women, more than 38%, and the person is obese. That is a more accurate estimation of obesity as compared to BMI. Of course, waist circumference also tells you that means more than 90 centimeters in males, more than 80 centimeters in females. Again, among Asian Indians, among Caucasians, the cutoffs are not 90 and 80, but I think 102 and 88. So this is just an average. That means on an average, India is obese because 25 and above is obese, BMI. This is based on BMI. And therefore, again, what Hippocrates is saying is that ultimately what we eat, all disease begins in the gut. See, we talk of these tubes in our body, embryologically. You have the most important tube, which then becomes the cardiovascular system. The second most important becomes the central nervous system. The third one becomes the gut. And the gut is, as you know, the entire alimentary system, including the liver and the pancreas. So that is also important. And then you'll realize ultimately metabolism, everything is at the heart of disease. Metabolism, if it is fine, no problem. So we are what we eat, and we are also what we excrete. So nowadays, your stool test is not a simple stool test. If you can actually look at the gut microbiome, whether it is balanced or no, that will also tell you a lot about yourself and accordingly how one can treat you. And as you know, nowadays there's fecal microbiota transplant, which is also being done. This is just to tell you the starch study done by Dr. Shashank Joshi et al., which clearly shows us that whether you're diabetic or non-diabetic, across the country, all the zones, including central, we are eating too much of carbohydrate. That has to come down. 50% should be carb. We are eating anywhere from 65 to 75%. It's not good at all. 20% protein, we are eating only 11%. Fat should be 30%, of which one third. So saturated fat, one third. Monounsaturated fat, one third. Polyunsaturated fat, one third. In fact, the saturated fat, you can even make it less than 10%, say 7%. And obviously fiber and micronutrients as well, because that enables us to utilize the macronutrient. Why am I saying all this when I talk about fatty liver? Is because if you don't eat well, then the excess carbohydrates that we eat get deposited in the liver cells as triglyceride, more than 5% hepatocytes. If they get triglycerides, that is the beginning of metabolic dysfunction associated steatotic liver disease. In the past, it used to be called NAFLD. So it's all to do with your diet. That is very important. So India is actually very paradoxically at the crossroads of both. Malnutrition, when you talk of it, is both under and over. So there's overnutrition and there's undernutrition also. We have a deficiency of micronutrients. But the best part is, even if you're obese or overweight, you may think you're overnourished, but it's the faulty type of nutrition. So there also you're undernourished because you have a deficiency of protein, deficiency of fiber, deficiency of micronutrients. So that is also malnutrition. And that's why some people call it MALL, mall nutrition, because we all love to go to the malls and then eat all the fast food and the junk food and the food that is not healthy. And that is the reason all of us have this problem, even children, adolescents, and young adults. And they are our future citizens. So my last slide before we get into this question answer session is ultimately, whether it's obesity or overweight, nutrition is your first, how do I put it, first weapon in your therapeutic armamentarium. Then, of course, exercise or physical activity, and then behavioral therapy. And yes, I'm not saying in sequence, everything can happen in parallel at the same time, concomitantly. Drugs also, because naturally, if you are very good with your diet and exercise, etc., you lose weight. And because of that, there'll be less resistance to the action of insulin. And then your drugs also will act better. And that's how one or two drugs have been approved for treatment of fatty liver disease because of a faulty diet. And they also become more effective if you combine those drugs with diet, exercise, and behavioral therapy. So OWN, own your health, because it's your own health. Please understand that in a year, a patient spends only 3 hours with his or her doctor and the remaining 8,757 hours with themselves. So obviously you need to be empowered with the right kind of information so that you can also take the right decision for yourselves about eating right, etc. And this way you are empowered now to control your disease and manage it rather than allow your disease to control. So that's all that I want to say. And now I'm open to, so I'll stop sharing, and then whoever wants to ask me questions, feel free to.
Thank you, sir, for this presentation. This was actually very encouraging, and like we should try and put forth all this information on the general public more often about how the BMI differences are there in the Western communities and the Indian community specifically. how all this obesity is on the rise and how it is affecting our health. It is because we all are doctors and we know all the things about related to these conditions. It is our duty to spread these awareness in the common public as well. So now I would like to request Abhilasha to carry forward the session and ask the questions. Let's have the conversation about this.
So it was a very good presentation, first of all. It actually enlightened and got a flow into what is MASLD these days. A lot of people don't know about it. Not just MASLD, people also don't know about NAFLD, which was the previous term used for MASLD itself. Thank you so much for the presentation. Now I will not take a lot of time and I'll directly dive into the questions. First of all, what we talked about was the diet being one of the primary risk factors causing or leading us to MASLD. Do you think, or are there any other causes apart from diet itself which lead to MASLD?
So one factor is genetic, but at the same time, there's not much one can do about genetics because, as you know, we can't select our parents. So at the same, I mean, that is something. Even if it is there, I feel there's not much we can do. So let's look at what is within our control, and what is within our control is obviously diet, exercise, etc. Apart from this, I mean, obviously we shouldn't be having too much of alcohol. Now, I agree that you might tell me, but sir, that is a different kind of liver disease, and that is called alcohol liver disease. Agreed. But at the same time, sometimes you may have a combination also of both. So that has also been seen. And sometimes there are drugs also that can lead to all this. But broadly, rather than get into the other causes, I would say just focus on diet, exercise, because when people get diagnosed to have MASLD, the first thing is to basically control diet, exercise, and then I mean, for a long time we didn't have any drugs. Now, of course, there are at least 2 drugs that have been approved, and I'm sure some more also will be approved going forward. But again, as I said, it's not just the drugs. Drugs will help, but you need to be very clear about your diet and exercise, and that itself can take care of many of these problems.
Okay. Apart from this, sir, okay, what are the clinical symptoms what we see in the patients when they come to the OPD, or in general, what are the symptoms that develop primarily when there is MASLD there?
So interestingly, per se, because of MASLD, and we look at only steatotic liver disease, actually you may not really have any symptom. But what happens is maybe the patient has come to the doctor for other things. Like, as I said, that person could be having hypertension. The person could be having what is called as pre-diabetes, because this kind of metabolic dysfunction associated steatotic liver disease is also a manifestation of pre-diabetes. And that's the reason one should also look for some other conditions. For example, obstructive sleep apnea is something which also is commonly coexistent with MASLD. So if like the doctor observes that the patient could be having, could be obese or overweight, then that is also something that needs to look into. The patient will not really complain of that, but the doctor, if he or she is, obviously well aware of this condition, then this part also has to be managed. So what I'm trying to tell you is that it's not necessarily a symptom-driven thing. Like, for example, if that MASLD progresses to metabolic dysfunction associated steatohepatitis, that is like a form of jaundice only.
Yes.
But the best part is that a plain MASLD, if you were to just do liver function tests, like it's basically a condition where you should have a very high index of suspicion. And then you should actually want to do certain tests like liver function tests. Now, there, it's strange, but in at least 50 to 63% of people, their liver enzymes may actually be normal. So that also is not a very clear way of diagnosing, because as I said, unless you have some damage to the hepatocyte, you may not necessarily get too much of these enzymes in the circulation. So that may not necessarily be diagnostic. So then the only way of really diagnosing, what people do are certain imaging tests. So these are non-invasive liver fat estimation or liver disease estimation. So one is they have MRI with proton density fat fraction, or they will do a fibrosis of the liver to understand whether fibrosis is already set in. So they have something known as fibroscan, or it's also called vibration controlled transient elastography, but basically trying to tell us whether this person, and there also there are certain stages, but when is that fibrosis clinically significant, that you will come to know from this liver stiffness measurement. So all these are important for then deciding at what level only a diet or your exercise, etc., is not enough, and you need to now use certain things, because eventually, as I said, it's not just MASLD or MASH. MASH will then go on to fibrosis, then to cirrhosis. Now, certainly we don't want the condition to progress to cirrhosis, because then it's almost like initially it may even be reversible, but subsequently it becomes irreversible. Initially it may be compensated, then it becomes decompensated, and then you can go all the way to hepatic encephalopathy, hepatic cancer. So then we have to maybe intervene. Of course, you need to refer such patients to a hepatologist so that a proper assessment is done. Endocrinologists, diabetologists also are, I would say, specialists in the treatment of this condition, because there's a lot associated with the fact that you could have diabetes or pre-diabetes, obesity, and naturally these doctors are specialists at treating those conditions. So endocrinologist is important, hepatologist, of course, and as you know, nowadays why the gastroenterologist is becoming more and more important for diabetes is because this glucose sensor, which we used to think is always in the beta cell in the islet of Langerhans in the pancreas, it is also in the duodenum. In fact, there is a particular endoscopic procedure which gastroenterologists do. I think it's called duodenal mucosal resurface. It's a resurfacing of that mucosal epithelium. And that also, people are saying it could actually help diabetes. So what I'm trying to tell you is that it's a multidisciplinary way of approaching that patient. It's no longer just the GP-CP. It's also these specialists who will need to get into the treatment at some point.
Sir, as we discussed, there is no clinical symptoms per se always present. Might be in a 2 or 2 have progressed a little in the disease. Actually, that was going to be my next question. What will be the progression symptoms, and it could if it could progress to some other complications of the liver itself or some other disorder was my next question, which you answered already in the previous question itself. So in that case, do we usually in the population see a particular vulnerable age group wherein if we do a preventive testing like screening tests to avoid the progression of MASLD, or if there is any susceptibility towards going towards MASLD, can that be done?
Uh, Actually, if you ask me, because of the burgeoning problem in India, where we are seeing it even with children, adolescents, and young adults. Previously, I would have told you maybe the typical, 40 years and above, 40 to 60. That is the age group when we should look for all this. But now I'm thinking, we see so many children who are overweight or obese. So actually,
Sir, your video is paused. No, he's back.
can you hear me?
Mm.
Sorry, I don't know what is the problem, but there's some network connectivity.
No problem.
No, again, I lost it. Can you hear me?
Yeah.
Yes, sir.
Okay. So then can I continue talking regardless of this networking?
Yes, sir. No problem.
So what I'm thinking is that I think it's more to do with looking at obesity and overweight, because if you look at MASLD, I mean, why did they move from NAFLD to MASLD? Is because they've realized that this condition is linked with metabolic syndrome. And all of us know what metabolic syndrome is all about.
Yes, sir.
And there is this constellation, especially among Indians. So which means it's like trying to rule out. One is okay from a central abdominal obesity perspective. But then what about pre-diabetes? What about hypertension? So which means all of these are linked. So if you ask me from a screening perspective, I would think anyone who, one is if they appear to be overweight or obese, then definitely we need to put them through this screening. The second is, unfortunately, among Indians, you have what is called as, you may be of normal weight, but metabolically obese. So MONW, which recently, I think Dr. V. Mohan had done this study across the country where he found at least 43% of Indians have what is called as, they are metabolically obese, but they're non-obese. What he meant by that is the same thing what I just told you. They are non-obese from a BMI perspective, but metabolically they're obese. And the second interesting thing is some people, they may appear to be overweight or obese, but metabolically they're healthy. So that's why it's important not to just go by BMI. You must estimate the adipose tissue mass and then also look at the metabolic syndrome. Does this person have at least 3 out of 5? And if that person has 3 out of 5, then you can say that this person is metabolically obese. So to answer your question, it's kind of difficult because it's trying to say that almost everyone needs to be tested for it, which is too much. So that's the problem.
Then going forward,
Sir, there's one question from my side. Personally, I have also seen this very often that even both doctors and the general public, they have very dismissive attitude toward this particular disease. Whenever someone is being diagnosed with fatty stage liver, fatty stage stage 2, or even fatty stage 1, they have this very dismissive attitude. In northern India, at least, we have to support that. So, what do you think should be our approach regarding this to change this attitude?
See, of late, we are also seeing many inexplicable cases where the person is young. The person may appear to be quite healthy, even exercising, and yet suddenly the person collapses and dies. Now, we really don't know whether in such people also there could be an underlying metabolic dysfunction associated, steatotic liver disease or steatotic hepatitis, which they didn't know about. Because what is important is that these are independent risk factors for cardiovascular disease. It's not just what I told you that it moves from hepatitis to fibrosis to cirrhosis to cancer. I'm talking of cardiovascular disease, which can happen much earlier. So unless a doctor or the lay public, unless they have experienced this in their own practice or in their family, they will not take this seriously. That I can understand, because if you ask so many of these radiologists or ultrasonologists, they are the ones who pick it up, and they also at the most they would tell the patient कि आपको diet पे ये करना है. That means they also know that this problem is because of the diet. It's not because of alcohol, but they just leave it at that. and then the patient may or may not, adhere to that dietary. So it's almost as if now doctors need to prescribe something, which can help the person correct his or her diet, as well as, I don't know how will you prescribe an exercise regimen. But unless these two things happen, this problem will continue, and it will really be picked up. Like even these drugs, which now the US FDA has approved, nothing is approved for MASLD per se. It's only when you get into MASH. And then, of course, you have to look at the fibrosis part and things like that. That is when these drugs get approved, because in an MASLD stage, it's very difficult to be able to state also that it is because of this drug that there is a statistically significant difference as far as outcomes are concerned. So that's why you have to wait for a MASH, and preferably a MASH with fibrosis, maybe not cirrhosis, but at least fibrosis, and then only you can evaluate these drugs. But I'm thinking these drugs which have just been approved for obesity, like semaglutide, which is now approved also for MASH, tirzepatide, which at least has a study in MASH. So later on, it might even get approved. So these are the drugs which I think people will use more often, and along with, of course, diet and exercise. And that is the only way to be able to get people to understand. Because otherwise, you're right. I mean, I fully agree with you that people feel that, as I said, no, 1/3 of Indians, they have this problem. And yet, I'm not seeing 1/3 of Indians dying. So it'll only be these sporadic cases, and then people need to investigate. So I'm sure there will be a few doctors also who will think like us, and we need to then get together. And as Pranav was asking me on LinkedIn also, and what I told him is maybe like how we say charity begins at home. So maybe we all need to do this first, not just in our homes, but in our societies where we live, and then gradually expand it. And then, of course, along the way, get some doctors also who think along the same lines. And I'm sure even the pharmaceutical industry, because they will realize that MASH is an important disorder. And if they have drugs that are approved for MASH, then they'll also be interested in improving awareness at least. And based on that, and as we know, even our Prime Minister has talked about the fact that we need to eat right. Even FSSAI has got this entire thing about eat right. So, it's like you have to partner with everyone, the government, the regulator, FSSAI in particular, medical bodies, professional societies, so those doctors coming in, dietitians, nutritionists, and everyone coming together. And as Pranav also told me on LinkedIn, it's important for people to have the right information also. Otherwise, they keep getting information from the wrong sources, which may be fake news or misinformation. And that should not happen, because then the price that one has to pay can be really very high.
Okay. Thank you, sir. So then all of this comes down to a position where even if somebody is diagnosed with type grade 1 fatty liver disease, technically he should be made more conscious, and he should be told that you need to have a lifestyle change apart from
Yeah.
just diet. You need to incorporate more amount of exercise into your daily lifestyle. You need to, if you can't hit the gym, increase the number of steps you're walking. Move out of your seats and just walk a little. That is all we can give that is all we can give ideas. The numbers are of course yet to be given, and they can be given by a hepatologist, I think.
Plus, as part of lifestyle, we should also remember sleep is important.
Yeah.
So they need to
Yes, sir.
sleep, for the right duration, but more importantly, the quality of the sleep also is important. So it is all about stress, and if stress can be actually reduced, one is of course healthy sleeping, and whatever de-stress kind of techniques are there, like transcendental meditation, etc. That also definitely would help.
Basically, people shouldn't just wait to getting into MASH or hepatitis or some complication of MASLD where, God forbid, not reverting back is not possible. Do not fall into that stage. Better take preventive measures from before. Are there any other preventive measures that we should be looking into our society per se? Because we see childhood obesity also very commonly, which would be a predisposition for MASLD. So in that matter, and also that as we say that Indians are per se more bent down towards falling into MSLD. As far as we have seen, we have a lot of central obesity patients in our OPDs, and also that in common populations also, central obesity is commonly seen. Similarly, these days, childhood obesity is also increasing. So in that matter, what do you think we should be incorporating into our day-to-day lives so that MASLD predisposition is reduced to a great extent from a very early age group itself?
You have actually touched upon a very, very important aspect for India in particular, and that is, as you rightly said, everything begins in the womb. And it's not just the womb, it is even before. It's like, I don't know whether you read this article which came in the Times of India recently, where I think the title was Mirror, Mirror on the Wall, who is fit, but who isn't at all. So which means that, and Dr. Chitranjan S. Yachnik was a part of that article, and he was saying the same thing, that even at birth, many Indian babies are insulin resistant. So what this actually means is that even before, two individuals, say to be parents, or in fact, even before that, if you want to get married, they need to be not just maritally compatible. The way, we go to this marriage counseling and things like that. So not only from that perspective, metabolically, are you fit? Because even if children, and then ultimately they are the ones who will become adults, they are the ones who will then get married, have children. If that fetus in the womb itself is, at risk, then it's almost like saying from womb to tomb, the child is doomed. So if at that level itself we can tell our youth that you need to really take this seriously, because you are the future of the country. Like you keep talking of Viksit Bharat 2047 and whatnot. But the point is that if this is what is going to strike our children, adolescents, young adults, then what is the real future? Now, will we really be an advanced nation by 2047? I don't know. Unless we decide as the youth of the country that we are not as healthy as we think we are. And everything actually boils down to what you said, a simple lifestyle modification. I know it's not as simple. That's why people say that you can change your religion, but to change your diet somehow is almost impossible. So that is the most important. That we can do and then inculcate. So it's all about fitness. The exercise part, the mental, that is also important because that drives whatever happens in our body. So yeah, I mean, this is something that needs to happen again at that level. So, for example, Foxy, they have this initiative called Adbhut Matrut. That means, if becoming a mother is a miracle. So can we make it, an experience of a lifetime? So where they're catching the mother when the person is becoming a mother. I'm trying to tell you even before that, that's the best time to catch.
Yes, sir. Okay, we looked up into prevention. How can we prevent it? Which you also told in the slides briefly, and also we discussed it how and when can it be started. That also we saw. Now, I would like to ask if someone is diagnosed to have MASLD, in that case, what can be done? Is it always that it is going to remain irreversible, or it might go into a stage where it is irreversible, where just the
See,
damage control can be done?
so initially, when diagnosed to have the very first stage, which is MASLD,
Mhm.
it is obviously reversible, and diet exercise itself, if the person is really motivated, can help in gradually reducing the fat deposition in the liver. And with diet exercise, and I don't know, some people even would start drugs, but very rarely. Initially, it's just diet exercise, which can actually reverse the situation. But if that person is not that motivated, then yes, it can progress. And especially genetically, also, they have found out some particular genetic marker that I think increases your risk towards developing cancer eventually. So such people will then progress faster. As you know, I mean, pre-diabetes to diabetes itself, Indians are the fastest to progress, something like 19% in a year. So on an average, 17%. That's the fastest among anybody else in the world. So this progression also from NASLD to MASH and then from MASH to fibrosis, all of that is when it can be reversed. Now, once it moves into cirrhosis, that is when it is very difficult for reversal as such. At the most, you can try to manage, control, and prevent progression. But whether you can cause regression is debatable. Of course, with these drugs that are now being approved, like resmetirom, which is apparently a thyroid hormone beta agonist, thyroid hormone receptor beta agonist, and now you have semaglutide, and I'm sure tirzepatide also at some point, and many others, like survodutide, and many others also are being evaluated. So with those kind of drugs, who knows, maybe some kind of regression can also happen. But above all, as you only said, it's the lifestyle. Because if you're not motivated enough to want to change the way you eat and exercise, etc., then all these drugs and all that are not really going to help much in the long term.
Okay.
So
Yes. Again, you answered a question which I was going to ask you again. That is medicines always going to help, or how much do medicines weigh in MSLD for treatment over your lifestyle modification?
so
Where
in general, I'll tell you that all of this, the non-pharmacologic treatment and then the pharmacologic, that's the way we have learned in textbooks.
yes, sir.
But the real world, what happens is doctors see these patients at a very advanced
First
stage.
medicine.
And many of these disorders, as you know, like diabetes itself, by the time the person is diagnosed, up to 50% of beta cell function is already lost. The person has lived with diabetes for at least 6 to 12 years for the UK PDS. So, which means doctors are no longer willing to take that, first I will do non-pharmac and then pharmac. So, what they do is they tell the patient, of course, to do diet, exercise, but they also prescribe a drug. So, any prescription you'll see, the drug, of course, is prescribed. But diet, exercise, because the doctor knows it's not too much under his control, he will, of course, recommend it. He'll write it on the prescription, but there's no way he can force it. But once he prescribes a drug, then more often than not, the patient will purchase, will take, and at least for some time, the patient is compliant. So there will always be a place for drug therapy for some time. It's like, even in depression, for example, why do we give drugs? Is because we want to get those neurotransmitters back to a balance. Because otherwise, just with other forms of therapy, they won't really always come to that balanced state. Thereafter, gradually, you can reduce the antidepressant and then continue with the non-pharmac. So similarly here, how I see it is, initially, if that patient is not very motivated to do only diet, exercise, etc., some drug will have to be given. But telling the patient very clearly that, first of all, if everything comes back to normal, it doesn't mean you're cured or something. If you continue eating in the wrong way, if you continue being physically inactive, it will come back. It's as simple as that. So if you want to be kind of free of all this, you must stick to your lifestyle modification, drugs for some time, till gradually I can decide when I can reduce and then stop it also. But I'll have to keep monitoring you, keep seeing you every maybe 3 to 6 months, and then we can decide. Because if a person is really motivated, yeah, you may not require drugs.
True. Uh, Moving forward, sir, what do you think for MSALD per se? What should be the initiative on our end? Like, as we being doctors, what should be our end initiatives towards creating its awareness, towards going forward the treatment, towards going forward in guiding the basic population also, who probably is not diagnosed or who might be on the way to get diagnosed someday, might be, not sure. So what do you think should be our initiative towards it?
So it's like this now among doctors also, as you know, some doctors take this condition very lightly,
Dismissal, yeah.
and they believe that till the patient progresses to MASH and fibrosis, anyway, there's nothing much that is approved for it. So at the most, they tell the patient to kind of just stick to diet, etc., and that they have no way of knowing whether the patient will really adhere to their advice or not. So therefore, we need to take the help of specialists, hepatologists, gastroenterologists, together with endocrinologists, diabetologists, and registered dietitians, nutritionists. Now, why I am mentioning RDN is because apparently these people, uh, when they pass an exam also to become a registered dietitian slash nutritionist, it is as difficult to pass that exam as a CA. I mean, CA also, the pass percentage is only 1%. So these kind of dietitian nutritionists, along with endocrinologists or diabetologists who specialize in diabetes treatment, and gastroenterologists slash hepatologists, these three mainly have to come together. And they need to conduct meetings through their societies or even individually. Maybe pharmaceutical companies can help in at least this awareness, that has to go through. So at least from a medical community perspective, everyone will know that this is a serious problem. It's not something that can be taken lightly. And thereafter, and thereafter, we need to obviously, as Pranav was saying, even go to the public and public awareness. So that is where even nowadays, even in these societies where we live, there also people do conduct these camps and health awareness checkups. Because see, ultimately, everyone need to understand that it is very expensive to be ill. Means you lose a lot of money if you are not fit, and then you have to go to a hospital and things like that. So whatever, on the one hand, we say the cost of healthcare is increasing, etc. In a way, it can be an incentive for all of us to be healthy, because if you're not, then we end up spending a lot of money. So I'm sure Indians who love to spend money traveling abroad, purchasing stuff. So that's why they love, that consumerism that we talk about. But at the same time, Indians will not want to spend on medical treatment. They need to understand that if they want the money to spend on other things, then they have to be fit. Otherwise, they lose all that money. Then who knows? Some people even go below the poverty line only because of this. So once they are told about this, what can happen? And also this other angle which you brought up about children, adolescents, young adults, early onset. That is where I think people should understand, because see, these people will be living with that problem for a much longer duration. So the burden that they have to face is much higher as compared to somebody who gets it only at the age of 60 or 65 or 70, because then they don't have 2 years to live, as compared to somebody who's very young and then entire lifetime he or she has to experience. So these are ways in which this awareness can really work. And of course, government and regulatory bodies, they also have to do whatever has to be done. Putting a tax on this kind of, the wrong kind of food, which has ultra processed, the sugar sweetened beverages, etc. That all some government or regulation only can help.
Moving, it's right. I think we all together need to get more awareness between us. It's likely that we ourselves in our community are not very sensitive, are not very known to such kind of diseases, which is just a first step for a disease which could get much worse, irreversible probably, leading to multiple hospital stays, rounds to the hospitals and like that. As you said, sir, that we need to get a group of multiple doctors of diverse intercommunities in ourselves only to get more awareness between ourselves first and then to the people. Very correct. We can move forward with that only. Now, coming back to the last question for the entire session. So, what is your key message about MSALD for the rest of the audience that we'll be having? And also, what do you think is the first step we can take on our food, on individual food, for avoiding to get into this entire cycle of MSALD? Please give us a note about it.
So in just one sentence, I will just say curb the carbs. So CURB, curb the carbs, because that is the one thing that can really, really help. The problem with all of us is we eat too much of carbohydrates, and that we need to really reduce and balance it out. So as long as our diet is balanced, that's why I had that slide which said MACHO. CHO actually also stands for, in Gujarati, we say a game show. So the show of game show, ultimately it's about carbohydrates. So don't think that because this person is eating so much of carbohydrate that he or she is prosperous, and a paunch is a sign of prosperity. Because as I said, having a paunch means you could also be having obstructive sleep apnea. So that is also something which needs to be looked at. Whatever it is, the point is that we need to start with ourselves first, and then obviously the people around us as well. So this fitness culture needs to come in, because otherwise, and when I say fitness, I don't mean go to the gyms and do exercise even at night and things like that. I don't mean that. Even a simple walk every day is fine. But it's about the eating. So I know there is this nutritionist who says zip the lip and move the hip. So what she means is that eat less, in the sense eat the right kind of food. It's not about eat less, eat the right kind of food, and move. Okay, that's good for your circulation.
True, sir. Thank you very much, sir. It was a very nice discussion.
Thank you very much, sir. And I feel like I'll be using that term carnivorous more often now.
Sure.
In northern India, at least we see our diet is mostly based on carbohydrates only. Like we use lots of potatoes in our diets. Potatoes
That's like
along
a
with
very common
chapatis,
place everywhere.
rice.
It might be potato in the north.
So
I would like to add a note to it, Pranav. It might be potato in the north, but there is rice in the south. Carbs
yeah.
are there everywhere, so you're not going to get away from it.
Yeah, so I'm not saying get away also. I'm just saying balance it. So
Balance it. Yeah, I
50%
guess
of
so.
daily and then 20 and 30. So that I'm with 5.
Yeah. And also that,
Thank you
like,
so
as you
much.
mentioned it multiple times, inculcate exercise into your regular habit.
Yeah.
Yeah.
Thank you so much, sir, for this.
So that was it, guys. I hope you liked it. And in order to keep getting more such podcast format informative videos, don't forget to like, share, and subscribe. See ya.